Now we start the part 2 of chapter 32, which is miscellaneous bacterial bloodstream infections, and we start with spirochetal infections. Classification and morphology. Spirochetes are thin, flexible, elongated, spirally coiled helical bacilli, spiria meaning coli, and chate means hair. Pathogens. Most of the spirochetes are saprophytes. Only three of them are major human pathogens, which are Treponema, Borrelia, and Leptospira. Spirochetes are gram-negative bacteria. However, their cell wall differs from the other gram-negative bacilli by presence of endoflagella. Okay. Now, endoflagella do not protrude outside but present in the periplasmic space between peptidoglycan and outer membrane layer. Okay. Now, motility. Endoflagella are responsible for various motility of spirochetes such as flexion extension type, corkscrew type, rotatory movement, and translatory type motility. The pathogenic spirochete differ in the mode of transmission and spectrum of the disease produced. They also differ in their morphological properties such as lengths and spirals, which we will see in the figures. Now coming to pathogenic spirochetes, first is Treponema, which has species like Treponema pallidum, which causes syphilis and transmission is through sexual contact. Treponema pertune, which causes yaws with direct contact. Treponema endemism, which causes endemic syphilis with direct contact. Treponema caretium, which causes pinta with direct contact. Now Borrelia recurrentis, relapsing fever epidemic, which is louse bone. Borrelia donti and Borrelia hermsii, which cause relapsing fever endemic, which is tick-borne. Borrelia burgdorferi, which causes Lyme disease, which is tick-borne, and Borrelia vincenti, which causes Vincent's angina, which is by direct contact. Now Leptospira species, which is Leptospirus interrogans, it causes leptospirosis. Milder form and severe form is Weil's disease. It is spread through contact with rodent urine. We can see the figures. Borrelia, which is longer and has lesser curves. Treponema, which is slightly shorter, has much more curves, and Leptospira, which is highly coiled structure. Treponema measures around 6 to 14 micrometer in length, possesses 6 to 12 number of spirals. Treponema pallidum causes sexually transmitted diseases called syphilis. Non-venereal treponemosis are other treponema species such as Treponema pertune, Treponema endemicum, Treponema carateum are transmitted by non-sexual mode, direct contact, and cause mainly cutaneous lesions. Borrelia are larger in size, 10 to 30 micrometer in length, possess 3 to 10 number of spirals. They cause various diseases such as relapsing fever, Lyme's disease, and Vincent's angina, which are discussed in this chapter. Now coming to Leptospira, it measures 6 to 20 micrometer in length. They possess numerous tightly coiled spirals with hooked ends. They cause Weil's disease, which is discussed here. Okay, now starting with leptospirosis. What is classification of leptospira? Leptospira is an antigenically complex comprised of two species, Leptospirosis interrogans and biflexa. Both can be classified into many serovars and serogroups based on lipopolysaccharide antigens. So Leptospira serogroups we can see here. This is Australia's eliminatives. These are all the various groups of Leptospira. It's not much required. Now, Leptospira interrogans comprise of 26 groups, which further consist of over 300 servovars. They differ in their geographical distribution and the severity of infection. Leptospira biflexa has 65 servovars and arranged in 38 groups. It is a saprophyte and not pathogenic to man. So coming with epidemiology, Leptospira interrogans causes leptospirosis or Weil's disease, a zoonotic disease that can cause liver and kidney damage, meningitis, respiratory disease, and even death if not treated promptly. Mode of transmission, leptospirosis is zoonotic. Direct human-to-human transmission does not occur. It is transmitted by indirect contact with water, moist soil, and wet surfaces contaminated with animal urine, or direct contact with urine and products of pasteurization, placenta of infected animals. Source. Although more than 100 animals can be infected, important sources of infections are rats, dogs, cattle, and pigs. Even asymptomatic animals can transmit the infection via urine. Seasonality. Leptospirosis is more common in rainy and post-monsoon period. Risk factors that promote transmission include lower socioeconomic status, urban and rural slum areas, rainfall and floods, occupational exposure like agriculture workers, example rice field planters, fishermen, sewer workers, and all those persons who are liable to work in rodent-infested environment are at increased risk. The three R's. The three important epidemiological determinants for leptospirosis include exposure to rodents, rainfall, and rice field. Incidence. The incident rate changes from 0.1 to 1 lakh per year in temperate climates to 10 to 100 per 1 lakh in tropical countries. During outbreak, the incidence may reach over 100 per 1 lakh. Global distribution. Leptospirosis is worldwide in distribution. About 1 million severe cases of human leptospirosis occur every year with a case fatality rate of 10%. Highest burden of the disease has been reported from area with high population density such as urban slums of Brazil, India and Thailand. In India, leptospirosis has been reported more commonly from coastal districts of Andaman and Nicobar Islands, hence called the Andaman hemorrhagic fever. Other states affected include Gujarat, Kerala, Maharashtra, Tamil Nadu, followed by Andhra Pradesh, Karnataka, Dadra and Nagar Haveli, Daman and Diu, Puducherry, Goa and Odisha. The samovas predominantly present in India are L. andamana, L. pomona, leptospirosis gripotyphosa, leptospirosis hebdomadens, L. semoranga, L. javanica, L. autumnalis, and L. canicola. Pathogenesis. There are two distinct phases of pathogenesis following the leptospiral infection. First phase, septicemic phase. After entering through the mucosa, conjunctival or oral, or abraded skin, example, leptospirosis, interrogants spill over the bloodstream and then disseminate hematogenously into various organs including brain, liver, lung, heart and kidney. Vascular damage. Spirochetes can be found in the walls of capillaries, medium and large sized vessels. The exact mechanism of vascular damage is not clear. Penetration and invasion of tissues is due to active motility and release of hyaluronidase. Second phase, immune phase. As antibodies develop, spirochetes disappear from the blood. Antigen antibody complexes are deposited in various organs. Renal colonization. Bacilli become adherent to the proximal renal tubular brush border and are excreted in urine. Clinical manifestations. The incubation period is about 1 to 30 days. In general, the manifestations can be divided into two distinct clinical syndromes. Mild anecteric febrile illness. It occurs in 90% of the patient. It's a biphasic septicemic phase. Occurs first followed by immune phase. It presents flu-like illness with fever, chills, headache, conjunctival suffusion, nausea, vomiting and abdominal pain, and myalgia. Weil's disease. Hepatorenal hemorrhagic syndrome. It is a severe form of icteric illness and occurs in 10% of patients. Typical biphasic course may not be present. It often progresses rapidly with a case fatality rate of 5 to 15%. Laboratory diagnosis. Specimens used are CSF, blood and urine, and microscopy is done. Dark ground or phase contrast microscope or silver impregnation staining reveals spirally coiled bacilli, tightly and regularly coiled, okay, with characteristic hooked end like an umbrella handle. Now isolation, culture condition 30 degrees Celsius for 4 to 6 weeks, and medium, EMGH medium, Korotkov's and Fletcher's media. Animal inoculation samples are inoculated into hamsters and young guinea pigs. Serology for antibody detection, genus specific test, macroscopic slide agglutination test, latex agglutination test, ELISA and ICT. 01 specific test, microscopic agglutination test, molecular methods, PCR detecting 16S or 23S rRNA or IS1533 genes, PCR RFLP and PFGE to detect genome species, non-specific findings, altered renal and liver function test. Now comes the laboratory diagnosis. Useful specimens are CSF and blood as we have discussed in first 10 days of infection and urine between 10 to 30 days of infection. Alright, about microscopy, leptospira are extremely thin, hence cannot be seen under light microscope. Leptos means fine or thin. Wet films, they may be observed under dark ground or phase contrast microscope. They are highly motile, exhibit spinning and translational movements. Staining, they do not stain by ordinary stain but can be stained by silver impregnation stain such as Fontana stain and modified Steiner's technique. Leptospirosis interrogans is 6 to 12 micrometer long, tightly and regularly coiled with characteristic hooked ends like umbrella handle. Hence the species name is interrogans, resembling interrogation or a question mark. Disadvantages: microscopy is less sensitive and requires technical expertise. Serum proteins and fibrin stands in the blood may resemble leptospires. Alright. Now coming on to culture isolation. Culture technique is laborious, technically demanding and time consuming, therefore not routinely used for diagnosis. Culture condition: leptospira is an obligate, aerobe and slow growing. Culture should not be incubated at 30 degrees Celsius for 4 to 6 should be incubated at 30 degrees Celsius for 4 to 6 weeks. Culture fluid should be examined under dark ground microscope for purpose of leptospires. Culture media, as leptospira is highly fastidious, requires enriched media such as EMJH liquid medium, Ellingson, McCulloch, Johnson and Harris, Krotkov's medium, and Fletcher's semi-solid medium. Serology for antibody detection. IgM antibodies appear even early, within 1 week of illness, reach peak levels in third or fourth week, and then decline slowly and become undetectable within 6 months. IgG antibodies appear later than IgM, reach peak level after few weeks of illness, and may persist at low level for years. Antibody detection test can be broadly classified into genus specific and servovar specific test. A genus-specific test uses broadly reactive genus-specific antigens prepared from non-pathogenic Leptospira biflexa patoc1 strain. They cannot detect the infecting servovar. Various tests available are ELISA, it detects IgM and IgG separately; leptodipstick assay, it detects IgM antibodies; immunochromatographic test ICT detects IgM and IgG antibodies separately. Servovar specific test microscopic agglutination test MAT. It detects antibodies against specific servovars of leptospirosis interrogans. It is gold standard method for the reference test and for the diagnosis of leptospirosis. Patient serum is mixed with microtitrate with live antigen suspicions of various leptospiral servovars endemic in the locality. Incubated for 2 to 4 hours at 30 degrees Celsius and then examined under diagonal microscopy for the presence of agglutination, as we see in the figure. Now, the cross agglutination and absorption test is CAAT. It is done to detect the relatedness between the strains. Coming on to the molecular methods, PCR has been found particularly useful in severe disease before servo conversion occurs. Various genus such as 32 kilodalton lipoprotein, L32 gene, 16S or 23S rRNA, or ISI 533 insertion sequence are targeted. However, PCR is not servovar specific. Non-specific findings: altered renal function, elevated levels of blood urea, nitrogen, and serum creatinine; altered liver function, elevated bilirubin and liver enzymes in the serum. Treatment: mild leptospirosis should be treated with oral doxycycline 100 mg twice a day for 7 days. Amoxicillin can be given alternatively. Severe leptospirosis, penicillin is a drug of choice, 1.5 million units IV 4 times a day for 7 days. Alternatives being ceftriaxone or cefotaxime. Alright, now coming to prevention. Vaccine, whole cell vaccines, mono or polyvalent, containing specific servovars of leptospira are available in many countries. Spirolept, manufactured by Sanofi Pasteur, is available for subcutaneous injection as 2 doses at 15 days intervals, with the third dose 4 to 6 months after the first dose, followed by biannual revaccination. The efficacy rate is around 60 to 100%. General measures: chemoprophylaxis with doxycycline is recommended for anticipated short-term exposures such as military training or traveling or freshwater swimming. General sanitation approaches, including proper waste disposal, rodent control, avoidance of swimming in contaminated places, and health education. Okay, so now first we discuss the images uh, from here. Okay, first let us discuss this table, which is the clinical stage of leptospirosis. First stage, 3 to 10 days, septicemic, in which fever, myalgia, headache, conjunctival suffusion, abdominal pain, pharyngeal erythema without exudates, and vomiting are present. Isolation is from blood and CSF. Serum IgM is absent, and antibiotic, it is susceptible to antibiotics. Second stage, 10 to 30 days, immune, meningitis, uveitis, optic neuritis, and chorioretinitis, rash, fever, and peripheral neuropathy are present. Isolation is from urine, and IgM is present, and it is refractory to treatment. Weil's disease, first stage 3 to 10 days septicemic, and second stage 10 to 30 days immune. High grade fever, liver jaundice 5 to 10% and raised liver enzymes, hemorrhages, pulmonary hemorrhage, fatigue and purpura, conjunctival hemorrhage, gastrointestinal hemorrhage, kidney, raised serum urea and creatinine, and renal failure. Isolation from blood and CSF and urine. In first stage, serum IgM is absent, while in second it's present. First stage is susceptible to antibiotics, while second stage is refractory to treatment. In this image, we see the Leptospira interrogans, spirally coiled bacilli with hooked ends. A is diagram microscopy of the mount following microscopic agglutination test, and B schematic diagram viewed under diagram microscope. Okay. Now this is ICT for Leptospira antibody detection, showing positive result for Leptospira IgM antibody. Alright. So this completes our leptospirosis. Now we start with borreliosis. Borrelia is the largest spirochete, 10 to 30 micrometer in length, consists of lesser numbered 3 to 10 spirals. Most of the species of Borrelia occur as commensals on the buccal and genital mucosa. Few are pathogenic to man, such as Borrelia recurrentis causes epidemic or relapsing fever. Borrelia burgdorferi is the agent of Lyme disease, and Borrelia vincenti is causes ulcerative gingivostomatitis called Vincent's angina in association with fusiform bacilli. All right. Now comes the relapsing fever. Relapsing fever is characterized by recurrent episodes of fever and non-specific symptoms following exposure to insect vector carrying Borrelia species. Relapsing fever is of two types, epidemic and endemic. Epidemic relapsing fever is caused by Bacillus recurrentans and is transmitted by louse. Endemic relapsing fever is caused by Borrelia species other than Bacillus borreliosis recurrentans, such as B. teutoni, B. hermsii, and B. turticati. It is transmitted by tick. Pathogenesis. Mode of transmission. Relapsing fever is a vector-borne disease. Epidemic relapsing fever, it is transmitted by Epidemic relapsing fever is transmitted by human body louse, Pedicellus humanus, and Borrelia introduced by crushing of the louse, example by scratching, leading to deposition of numerous spirochetes on the abraded skin and mucous membranes. Endemic relapsing fever is transmitted by bite of an infected tick Ornithorodus species. From the inoculated site, Borrelia spreads rapidly, leading to bacteremia and fever. Host immune system tries to eliminate the bacilli from the body. However, the borrelial surface antigens frequently undergo antigenic variation. Each time, new antigens are produced, which can evade host immune system, leading to repeated bacteremia and recurrent febrile episodes. Clinical manifestations. Both epidemic and endemic relapsing fever have similar manifestations, although not identical. Incubation period is about 7 to 8 days. Recurrent febrile episodes lasting for 3 to 5 days occur, intervening with afebrile episodes of 4 to 14 days. Relapses can occur up to 10 times. Subsequent episodes are shorter. Hemorrhages, petechic epistaxis of blood and tinged blood epistaxis and blood tinged sputum are more likely to occur in epidemic relapsing fever. Neurologic features such as meningitis, seizure, focal deficits, paraplegia, and psychosis may occur in 10 to 30% of the cases and more common in epidemic relapsing fever. Now, the laboratory diagnosis, microscopy. Microscopic features of Borrelia have been described earlier. Various methods available to detect Borrelia from blood are peripheral thick or thin smear stained by Wright or Giemsa stain, direct fluorescent antibody test using monoclonal antibodies employed to identify the species. Now, in this figure, we can see the peripheral smear showing Borrelia species Giemsa stain, with this arrow is showing the Borrelia species. Okay. Dark ground or phase contrast microscopy to demonstrate motile spirochetes but low sensitivity. It is poorly gram negative culture. During afebrile period, microscopy fails to detect Borrelia, hence the confirmation is made by isolation of Borrelia from blood. Serology. Then for detection of antibodies, ELISA and IFA indirect fluorescence assay are available to detect serum antibodies. GIPQ assay is the most reliable serological method. It is an immunoblot assay detecting antibody against the recombinant GIPQ antigen, glycerophosphodiester phosphodiesterase. Molecular methods. Multiplex real-time PCR has been developed targeting 16S RNA and GLPQ genes to identify the various species of Borrelia causing relapsing fever. Treatment of relapsing fever. Antibiotics such as doxycycline or erythromycin are the drug of choice for for the relapsing fever. Recommended schedule is single dose for epidemic relapsing fever and 7 to 10 days course for endemic relapsing fever. Lyme disease. Agent Lyme disease or Lyme borreliosis is caused by Borrelia burgdorferi. It is widespread in USA but also reported from other parts of the world like Europe and Asia. Rodents and deer are the main reservoirs. It is transmitted by tick bite, Ixodes ricinus complex. Alright. Now, the clinical manifestations. Lyme disease occurs through the following stages. Stage 1, early localized infection after an incubation period of 3 to 32 days. An annular maculopapular lesion develops at the site of tick bite called erythema migrans, commonly involving thigh and groin. Stage 2, early disseminated infection. Borreliosis burgdorferi spreads hematogenously to many sites, resulting in secondary annular skin lesions, arthralgia, malaise, and neurological abnormalities. Late persistent infection, Lyme arthritis. About 60% patients develop arthritis of large joints, example knees, lasting for months, which may be refractory to the treatment. Laboratory diagnosis. Isolation of Bacillus burgdorferi can be done by culturing specimens like skin lesions, blood, or CSF in special medium called BSK medium, Barbour, Stoner, Kelly. Molecular methods. PCR detecting specific DNA is more sensitive in joint fluid, but its sensitivity poor for CSF, blood, or urine samples. Common gene targets include 16S rRNA, FLAP, and OSPA, outer surface lipoprotein. Serology, antibody detection. The most common method of diagnosis of Lyme disease is by characteristic clinical picture with a positive serological test. CDC recommends two-test approach. First, ELISA should be performed. If found positive, it has to be confirmed by Western blot. Increased leukocyte count. Joint fluid examination reveals elevated polymorphonuclear cells, whereas CSF shows lymphocytosis. Okay, for the treatment for all stages of Lyme disease except CNS and CVS infection, oral doxycycline is the drug of choice except for children where amoxicillin is given. Duration of treatment is 14 days for skin lesions and 30 to 60 days for arthritis. For CNS or CVS infection, cifratrexone is given for 14 to 28 days. Now, first question. Write an essay on question. A young farmer was complaining of fever, headache, and myalgia. Gradually, he developed yellow discoloration of skin and sclera. On examination, he had conjunctival suffusion and hepatosplenomegaly. His blood count showed neutropenia with thrombocytopenia. Liver function test showed an elevated conjugated bilirubin and mild elevation of transaminases. He was also found to be oligouric and uremic. So clearly this is a case of leptospirosis. So we can write the etiological agent and how the disease is transmitted, typical clinical presentation, confirmation of the diagnosis, and the management. Okay. Now write short notes on brucellosis, relapsing fever, and Lyme disease. We have discussed in theory. First MCQ is Brucella millentis is commonly found in which animal? So it is commonly found in goat. Malta fever is also called as what? It's called as undulant fever. The following drugs are indicated in brucellosis except streptomycin is given, doxycycline is given, meperidine is not given, and rifampin is also given. Fever in brucella infection is described as what? It is described as relapsing fever type, right? Undulating fever. Okay. The most common mode of transmission of brucella is by first direct contact. The classical triad of brucellosis includes all except meningoencephalitis. Which of the following is gold standard for diagnosis of leptospirosis? It is the testing acute and convulsant phase sera for anti-leptospiral antibodies by microscopic agglutination test. Okay, and which is the correct statement about relapsing fever? It is that each relapse is associated with an antigenically distinct variant. Which disease is caused by Leptospira interrogans. Okay, so this completes our chapter. Bloodstream and cardiovascular system infection, which includes miscellaneous bacterial bloodstream infections. Okay, so in next video we'll be continuing with the next chapter. Meanwhile, like, share, subscribe. Thanks for watching.